We are live now, doctor.
So, good evening, everyone. Welcome to one and all from Chennai. As a president of Tamil Nadu Ophthalmic Association, it gives me great pleasure in welcoming each and every one of you for this international pediatric webinar, Eye-Conic Evening with the Pediatric Masters. At the outset, I'd like to thank Shruti and extend my deep appreciation for getting so many people on board from different parts of the globe. And also, I'd like to thank the faculty for sparing their time and trying to connect in spite of the difficulties that they would have faced. So looking forward to a very fruitful scientific discussion. I'm sure with the amount of expertise that all of you have, we're going to have an excellent webinar today. So before I move on to the actual webinar, I would like to request my Tamil Nadu Ophthalmic Association Secretary, Dr. Chandrasekhar, to say a few words before we move to the introduction of the panel.
Our respected President, distinguished guests from across the world, and our dear old friends, it is indeed wonderful to see such a wonderful, it is good morning and good evening to all of you, and such a good host, and I should really congratulate Shruti for this wonderful meeting. So I must say one thing, during Corona time, it was Dr. Mohan Rajan sir who actually made the best use of this online programs. And now Dr. Sujata madam has taken it 2 steps forward. And in the last 2 months, we have been doing so wonderfully well, giving wonderful programs, wishing this program a wonderfully all the very best and successful program. Thank you, madam.
Thank you, Dr. Chandrasekhar. Manjula, can you share the slides for the panel introduction?
Sure, doctor.
So first and foremost, I'd like to invite Dr. Sumita Agarkar. She's a director, Department of Pediatric Ophthalmology and Strabismus, Shankar Nethralaya, Chennai. Next, we go on to Dr. Sandra Ganesh, who's a medical consultant, pediatric ophthalmology and strabismology at Aravind Eye Hospital, Coimbatore. Then to Dr. Muralidhar, head of the Department of Pediatric Ophthalmology and Neuro-Ophthalmology, the Eye Foundation, Coimbatore. And Dr. Manjula Jayakumar, Senior Consultant, Department of Pediatric Ophthalmology, Dr. Agarwal's Eye Hospital and Research Center, Chennai. Really extremely glad that you could join and be discussants for this wonderful faculty. Thank you. So we move on to the introduction of faculty and the speakers.
Yes, thank you, ma'am. Thank you for this wonderful opportunity to be able to help and facilitate with this webinar. Dr. Sujata came in with one phone conversation saying that I wanted to have something that's the international panel of wonderful speakers and something that's truly spectacular for all pediatric ophthalmologists and general ophthalmologists. And I said, let's do it. And here we are today as a dream that's come true for us. I sincerely thank Dr. Murli sir, Dr. Sandra, Dr. Sumita Agarkar, and Dr. Manjula, who really helped put together and really helped with connecting with these stellar speakers tonight. And also a really kind word to Dr. DC sir and Dr. Sujata ma'am, who kept pushing me from the back. And so today we have a lineup of wonderful talks by good, excellent speakers. And I would request the IT department just put up the first slide. And I would like to introduce the first speaker of today. And this is none other than I think it's Dr. Padmaja. Yes, Dr. Padmaja Shankriturk. She's the head at the Global Myopia Management at Zeiss Vision Care and also the conjoint professor at the School of Optometry and Vision Science at the University of New South Wales. Now, in the myopia field, she needs no introduction. She's a big powerhouse of information and knowledge of wisdom and wealth. And of course, she's our very own. She's from India. She's in fact from Chennai. So that makes very endearing for us. And over the years, she's held various positions at LV Prasad in Hyderabad, University of New South Wales, and Brian Holden Vision Institute. And of late, she's been pioneering certain important papers on the axial and percentile charts, which is something we've been really adapting it into our practice, as well as the BHVI myopia calculator, which has somehow helped us guide our patients in a much better way, I would say. So thank you so much, Dr. Padmaja, for accepting to talk to us today, and over to you for the talk.
All right. I'm going to try and share my slides now. I guess you can see my slides, okay?
Yeah, we can.
Yes, we're good.
Okay, good evening, everyone. I'd like to start by thanking the association for inviting me to present at today's webinar, and especially to Dr. Sujata Mohan and Dr. Shruti Nishant, who coordinated the entire episode. My disclosures are listed on this slide. Moving to the next one. All right. Okay, I guess most of you probably familiar with this figure to the right, which indicates that by the year 2050, nearly half of the world's population will be myopic. Very recently, at a meeting held in Vietnam, Dr. Tim Frick, who was on the original author list, and he's been looking at the data since the Holden publication, because that publication was in the year 2015. And he has been looking at the evidence since then, and he sort of said, okay, there appears to be some regional variations in the prevalence since the Holden publication, but it appears that we are on track to reach the figure of half of the world's population going to become myopic, and it appears that we might reach that figure much earlier than anticipated, that is by 2040 instead of 2050. And that is quite a significant finding, and one that we have to consider going forward. Now, fortunately for us practitioners, we do have a number of interventions that are currently available for us that can slow the progression of myopia. And as you know, we've got optical interventions looking at spectacles, contact lenses, and ortho-K. We've got pharmaceutical options by way of atropine. And then we've got low-level red light therapy. This figure is from the recent IMI interventions paper, and all of the y-axis is very similar. So you can sort of visually see where the interventions sit at the present time. And it appears that red light therapy is the most effective, followed by high concentration atropine. And then we've got orthokeratology, which seems to be quite similar to that of spectacle lenses. And then we've got soft contact lenses. And we do know that low dose atropine is not effective. When it comes to treating myopia, clearly the target for us is to avoid high myopia and to slow myopia as much as possible, because we know that each diopter increases the burden associated with myopia. But I guess, so that means, yes, we as practitioners, we have multiple tools available to us at the present time to slow myopia. But I guess the question is efficacy everything? And we know that that is not everything when it comes to individual patients that come into our clinic. We've got to evaluate a number of things before we decide what is the right treatment strategy for a given patient. And we've got to consider the cost effectiveness, quality of life related to these interventions, safety. And specifically when it comes to myopia control interventions, we are having to work through some of the issues which are unique to these interventions, which is reduced efficacy over time, rebound that has come up in many conversations, and importantly, as to who might be responding to these treatments and who might not be. And I'll try and quickly go through each of these areas at the present time. So if we look at cost effectiveness of interventions, so there's been 2 publications so far, and I was involved in the first publication that was conducted across Australia and China. So what we did for this exercise was to simply consider an 80-year-old myope who is 3/4 of a diopter, and then we charted what are the costs associated across the lifetime of this myope. When they're young, clearly they would require treatment to manage the progression of myopia. When they're older, they might be requiring single vision lenses. A little bit older, they might require progressive addition lenses. And then when they're much older, there might be risk of complications and the costs associated, not only the devices and the treatment costs, but also the costs associated with seeing a practitioner. So we included everything. And what you see in dark letters there is the cost associated with simply managing them with the single vision spectacle lens. And then we evaluated all of the myopia control interventions, spectacle lenses, contact lenses, ortho-K, atropine. And the figure in gold color is the one that was shown to be the most effective or most cost-effective intervention. And we see that for Australia, UK, and France, it is anti-myopia spectacle lenses that are most cost-effective. Whereas in China, it was atropine followed by spectacle lenses. Everywhere else, following anti-myopia spectacle lenses, it's atropine in Australia and then ortho-K, surprisingly, for France and UK. So we are beginning to see a trend here where we are seeing that spectacle lenses are the most cost-effective. Then what about the quality of life? And as all of you know, quality of life is measured across several domains. For example, we might be thinking about the visual experience or the symptoms associated with using a particular strategy, or the social aspects of quality of life. And we know that quite clearly with respect to cosmesis. So when you look at the quality of life with respect to myopia, and this is not unexpected, we know that quality of life data is worse for uncorrected myopic eyes than corrected myopic eyes. And even when corrected, it is worse for higher levels of myopia, probably because they require specialized treatments, which make it quite overt for a person to see that they're wearing highly powered spectacle lenses. And then when we look at the treatment strategies, clearly we see that contact lenses are not okay, fare better than spectacle lenses. And that's a bit of a no-brainer because of the cosmesis afforded by contact lenses and okay. Then when we consider the myopia control interventions, because we want to be sure that myopia control interventions do not make quality of life worse, unfortunately, there's not much work done in this space except for one article that compared single vision and myopia control, one of the myopia control lenses, the DIMS lens. And here we find that the quality of life is quite similar between single vision specs and myopia control spectacle lenses. And so that information is quite promising. Then we've got to consider the safety aspects of these interventions. With respect to spectacle lenses, what comes through is what might be the visual performance of these lenses, especially given that, there is a treatment zone where there is myopic defocus. And there's questions asked around whether it might be safe for children to wear such lenses, whether they might fall off their bikes, or whether they have issues with reading with these lenses on. With respect to contact lenses, the same questions apply with respect to visual performance. In addition, we've also got to consider adverse events, infection, inflammation, and mechanical events. For atropine, again, visual performance, as well as side effects, as well as there is a question around long-term safety and what it might do to the functional response of the eye. And low-level red light therapy, it's a new kid on the block, but there's a big question around safety of low-level red light therapy. And then when we look at the data that we have at the present time with regards to these questions, we do see that with myopia controlled spectacle lenses, there is some reduction in contrast, peripheral contrast and peripheral VA, but not enough or not significant enough that it would hinder performance. And there's also some studies done around reading assessments and so on, and they show no decrement in performance. Similarly with contact lenses as well, and specifically with respect to adverse events, it is said that they're similar to what you see with adults, and we know that daily disposable lens wear is quite safe. With respect to atropine, it is quite well known that you would have blurred vision, glare, especially with higher concentrations, that then necessitates that we consider photochromics and possibly near ads with these things. And also there's a question around the retinal function. There's some work that has been done, but not significant enough that we can answer this comprehensively. And then low-level red light therapy, and yes, we still need to see data which puts low-level red light therapy in the clear. So there is some data trickling through, but not enough for us to have a comprehensive understanding. So based on all of this, what we are seeing is that myopia-controlled spectacle lenses have emerged to be the most widely used myopia control intervention, and it's quite rapidly rising because, yes, they're quite efficacious, and there's now some data that's up to 6 years. They're safe and non-invasive. The fitting procedure is quite simple. The follow-up process is not significant, same as what you would do with single vision lenses, no specialized skills required. And more importantly, they're accessible and convenient and can be accessed by population in whichever part of the world they might be living in. So yes, so we know that we've got those categories and we understand where they sit. So now as a practitioner, if I were to try and understand what I know what the things available to me are, and now I want to try and fit a patient with these lenses. So if I were to look at the options available to me, then if I look at myopia control spectacle lenses, generally you would have to pick a design. There's not much availability in terms of within a particular design that there is either high power, medium power, or low power. It's generally designs. So for example, HAL and DIMS lenses, they have lenslet designs, whereas K has got cylindrical annular rings. Similarly, with contact lenses, we talk about dual focus lenses, which are nothing but alternating rings. Or you try and pick a lens which has got extended depth of focus profile or a center distance multifocal. Similarly, with ortho K lenses as well, they're all based on designs. With atropine, you can pick and choose the concentration that you believe is appropriate for a given child. And low-level red light therapy is a single wavelength that is available at the present time, although people are looking at other wavelengths as well, and they're also assessing LEDs to see red light LEDs to see whether even they can slow progression of myopia. So we picked our design, and the variables that we consider in terms of myopia management are quite simple. It is spherical equivalent refractive error and axial length. Now, again, we all know that cycloplegic refraction is the gold standard when it comes to diagnosing myopia. Because non-cyclorefraction, it's quite clear that it overestimates myopia, especially in those with low levels of myopia, emmetropia, and hyperopia. However, there might be a situation where one might have to consider non-cycloplegic refraction, and if that is the case, then generally the advice is that they should combine that with visual acuity to try and work out if the child is indeed myopic. For example, if the non-cycloplegic refraction reads minus 1.25, but the child reads 6/6 line, then we know that probably it's because of the non-cycloplegic refraction and accommodation that you're reading this error. And there's more recent work that is supporting the use of ALCR as well as a tool to detect myopia, not so much to diagnose the level of myopia, but to detect myopia. In terms of axial length, we know that it is quite accurate, and it is increasingly coming into the conversation when we talk about myopia management, but we are all very clear that it cannot be used to diagnose myopia, and it is a tool to monitor progression of myopia. There are percentile curves. So if you take a reading and you see that an eye is 25 millimeters, then you can use that in the percentile curves to try and understand the relative risk of this particular child, relative to the population. So that's the starting point, so to speak. Then when it comes to what we do in terms of monitoring a child in fitted with one of these interventions in myopia management and to try and understand whether a treatment strategy is efficacious or not. At the present time, there are no unified guidelines. There are a number of consensus statements and guidelines that appear to be specific to a region, and they might vary based on age and ethnicity. One thing we know for sure is that past progression of a given child is not a reliable predictor of future progression. Therefore, it should not be used. Generally now it appears that the field is using the emmetropic eye growth as a guide to monitor efficacy and to try and see whether you can slow eye growth to that of emmetropic eye growth. Because in a clinic, if you're sitting as a practitioner, there is no single vision group to compare with. So you need to have a figure to try and guide you, to try and work out whether that treatment strategy is successful or not. So if axial length is going to be used as a measure to guide the treatment strategy, then most commonly used value is 0.2 millimeters or less when the child's age is less than 10 years, and 0.1 mm when the child is more than 10 years of age. And if you want to combine this with spherical equivalent, then again, 0.5 diopter growth per year, 0.5 diopters or less growth per year is considered to be successful. So we've monitored the efficacy. So what happens long term? And here again, we do know that with most of the interventions that are out there across all of the strategies, optical, pharmaceutical, or other things, we do see that long-term efficacy seems to taper off. So for example, if we look at year 2 efficacy compared to year 1 efficacy, so you see that in the figure to the right, that it appears to be anywhere from 30 to 70% of what you saw as the efficacy in year 1. So why might that be the reason? We do not know very well as to what could be causing that. There are a number of factors which are related to the individual or to the eye that we think might be responsible. Because this data is coming from clinical trials, one reason could be that fast progressors, if you're progressing fast, you don't want to stay in a clinical trial because you want to leave the trial and go and get yourself treated. So fast progressors leaving the trial would mean that the control group progression would become slower, or test and control group become closer, and that might be one of the reasons. We do know from data from a number of studies across various strategies that compliance has got quite a significant role to play. So here I've got data for one of lens types that's available in China, and the dots, the black circles, are single vision lenses. And you see that irrespective of the time worn per day, it appears that there is no difference in efficacy. Whereas if you look at the myopia control spectacle lens, the data for myopia control spectacle lens given in the blue triangles, you can see that the efficacy is increasing with increasing wear time. And that is quite significant, and that is noted across, like I said, across other interventions as well. So if the child or the parents feel that, yes, the bub is doing well in these lenses, and come home, they don't need to wear their lenses because they can see quite clearly at near, then that could be one of the reasons why we are seeing a drop-off in efficacy. Or it could be that there is some sort of an adaptation process happening in the eye. If the receptors in the eye, and we don't know what they might be, whether at the retinal level or the ganglion cell layer level or other layers, if they're responding to the signal, initially if more responded, whereas with time, if few of them are responding, then it might be that we are seeing an adaptation effect. And such examples are not uncommon with respect to what we see with the eye. Or it could be that the disease itself or the condition itself is progressing, and what might be effective at a certain stage of the condition is not so effective as the condition is getting more complex. Or in other words, if the eye is at 24 millimeters, it might be responding, but if it is at 25.5 millimeters, it might not be responding. However, we think that this is the unlikely of the scenarios because we do have data that shows that these interventions are effective at at a smaller eyes as well as longer eyes as well. So we don't know why that is happening, and the field is trying to work out what we can do to try and maintain the efficacy. And then we've also got this issue of non-responders. We assume, because all of the data is coming from clinical trials where you're looking at the difference between the test and the control group, you really don't know who of those children who received the test lenses actually responded to the treatment. And the only way we can try and ascertain that is from what we call a crossover clinical trial, where each child tests both the single vision lenses as well as the test lenses. And we conducted such a trial again with this lens that I mentioned previously. And the lines that so each child wore single vision lens for 6 months and the myopia control lens for another 6 months. And the order was randomized. So the green lines are the ones where the progression in the single vision lens was more than the progression in the myopia control spectacle lens. Or in other words, the green lines indicate successful treatment and the pink lines indicate that the lens was not successful in slowing myopia. And luckily for us, we see more of the green lines than the red, than the pink lines. And in fact, with this particular lens type, we saw that 8 out of 10 eyes responded well to treatment. So we knew exactly which child responded to the treatment. But that also gave us an opportunity to try and understand why the other children might not be responding. There were only few of them, so we looked at all of the factors related to those non-responders. And what came out from that was that those who did not respond well to treatment actually reported less comfort to begin with, and their wearing time was less as well. That again tells us that it probably is related to compliance than to any of the other factors, which is quite interesting. But again, that's a pearl that we can take back into a clinical practice to make sure that, we're fitting these children right in their lenses and also evaluating their subjective experience, because if they're not comfortable, they're not going to wear the lens and you're not going to get the required efficacy. So we've done all of that, and we find that, yes, some children are not responding, despite you checking on compliance and so on, or that the progression is not what you expected it would be, or in other words, it wasn't quite to the level that where you wanted it to be. And in addition, there might be a group of patients that you might right at the start deem to be high risk. And for example, parental myopia, quite aggressive, fast progression in the past. In such cases, you might want to consider combination therapy, and combination therapy is getting quite popular at the present time. So when we look at combination therapy, it's generally atropine that is combined with other treatment strategies, orthokeratology, soft contact lenses, spectacle lenses, and so on. However, the evidence is conflicting. There are some studies where they're saying, yes, there is an improvement when you do combination therapy, and there is equal number of studies that are showing that there is no support for combination therapy. So it's a field that is evolving, and we are learning as we go. However, we do know that 0.01% atropine is not effective. And we don't know why combination therapy is effective. Is it because of a synergistic action, or is it because the two strategies are working through different pathways? So if one fails, then the other one is responding, and reason why you're seeing efficacy. So again, all of that needs to be worked out, as well as working out what might be an optimal combination and how we should time this combination therapy. So the last one to talk about is rebound, because rebound is quite significant when it comes to atropine, especially with higher concentrations of atropine, as well as with low-level red light therapy. So there's always this question as to what might happen when children come off treatments, including optical strategies and even regulatory bodies. For example, FDA is requiring that we demonstrate that there is no rebound with these interventions. It is quite a difficult thing to try and address, especially in a clinical trial, because if a product is successful, you don't want to take that off a child and then put them back in single vision just to see if there is going to be rebound. But it is a question that comes up more often than not. And again, the crossover clinical trial sort of gives us an opportunity to try and understand whether there is any rebound, although it is only short term. So here what we did in this particular trial, as I mentioned, was we randomized children into a myopia control spectacle lens given in blue and a single vision spectacle lens given in this black line. And at the end of 6 months, we crossed them over. So the question is, when children wore the myopia control spectacle lens for the first 6 months, and they moved into single vision, was their rebound? So for that, what we did was we looked at the progression in the second 6 months of this arm and compared it to the single vision progression in the first 6 months for the second arm. So that's given in this table here. And what we see is that both in terms of spherical equivalent progression and axial length progression, there is no difference. And this is not the first study to show this. There have been other studies, especially with myopia control spectacle lenses that I was involved in, where again we showed that there was no rebound. However, as I said, this is short term, like we evaluated lens wear only for 6 months, and therefore there is still a need to try and understand if that is the case after long-term wear of these lenses. So to summarize, I mean, myopia management is quite a dynamic field, and there's lots happening, a lot of strategies that are being considered and treatments coming in pretty much on a regular basis. But it is just not efficacy, as we went through, that we would have to consider when it comes to applying a treatment strategy for a given child. There's multiple other factors such as safety, cost effectiveness, quality of life, and so on. And we are seeing that myopia controlled spectacle lenses are emerging to be the most widely adopted mode of myopia management. But there is still a lot more work left to be done around long-term efficacy, how we might want to optimize treatments. Is there rebound? What level of rebound? And why is it that some children are not responding to these approaches? With that, I'll finish, and thanks very much for your attention.
Thank you so much, Dr. Padmaja, for such an illuminating perspective on the understanding of myopia and how to clinically adapt it into our practice as well. Especially very insightful was about the rebound and how it's actually just a progression of the natural course of myopia, not necessarily a rebound. And also the reduction in the efficacy, which we are all seeing overboard. So I think we'll have our panel to discuss this further. Can I invite Dr. Manjula and Dr. Sandra? Maybe we'll have Dr. Manjula first to have her question. Ma'am, you're on mute, if you could.
It was a very nice talk, Dr. Padmaja. I would like to ask you some practical questions. We know that determining what kind of therapy we have to offer our patients, we depended on the patient's vision, their ocular condition, their family preferences. But do you also kind of look at age-based treatment options? For example, if the child is 4 years, would you like to start on low-dose atropine? And if the child was older, say around 8 years, you would like to start on defocus glasses. Anything based on the age of the child would you suggest a particular treatment option? This is the first part of the question.
It's actually a good question. And as I was saying, I'm actually in China at the moment for a conference, and I've been visiting eye hospitals, working with collaborators. And in China, this sort of age related management guidelines seems to be adopted across some of the centers. So they've got from their experience, they've worked out exactly like what you said, when a young child comes in, if a child comes in 5 years of age or 7 years of age, they have two parents myopic, they decide what intervention that the child would need to go in first. So when it comes to very young children, yes, especially if they are deemed to be high risk, there is a preference towards using atropine. But again, the data seems to be suggesting that low-dose atropine is not effective. 0.01% is not effective. So most of them are now preferring to use myopia controlled spectacle lenses, unless they feel that, you know, that person is at a very high risk, in which case some of them are starting them on combination therapy, myopia controlled spectacle lens, as well as atropine, because the child would still anyways require treatment. So that, but that definitely is something is of a pattern that I'm seeing here in China. And older children, they tend to give, for example, if it's a much older child, then they might talk to the child, and if there is a need for the child to play sport and other things, then ortho-K seems to be coming into play. But again, the preferences for one treatment versus other seems to vary by region.
And most myopes do not stabilize by the age of 16 years. So do you like to control these treatment modalities further beyond 16 years, maybe even up to 20, across 20s? So how long is the treatment recommendation?
Yes, that again is a very good question, and one that we've been researching very closely. So we call them young adults, and we've looked at data from 18 to 25 years of age to see do they become myopic during that period and what their progression might be. And basically what the data is telling us is that 18 to 21, especially in that bracket, and if they have a student status, which is practically everyone going to university, then they're likely to progress. Approximately 25% of them show what we consider fast progression as well, so 0.5. So 18 to 21 student status, yes, there is still a risk of progression, and nearly a quarter of them are showing fast progression as well. So now it does look like that we would have to consider treatment strategy for young adults. But another thing that comes into play there is that young adults are generally more discriminatory when it comes to what sort of treatments they get. Their lifestyle is completely different to that of a child. They're more likely to spend time outdoors, spend night outdoors. So therefore, some of the treatment strategies where, for example, there are subjective symptoms like glare or halos around light, then they're not going to like them. So it looks like one might have to look at specific treatment strategies for young adults.
What about
Dr. Sandra?
Yeah, Sandra can
I'm sorry, as a part of the thing, I mean, we just have to really look at time as well, and that's a difficult job of the moderator here. Yes. So just for issues. The task of timekeeping, I would like, Dr. Sandra, one question from you, and then we'll move on.
Yeah, thank you. And thanks, Dr. Padmaja, for the excellent talk. So my question is on the red light therapy, which you mentioned is the most efficacious management line as of now. I note with interest when you said that. So is that from real world studies or is it from the clinical trials? And which part of the world is that data from? And secondly, what would be the cost effectiveness of using red light as the therapy modality as compared to myopia control spectacle lenses? Thank you.
So much of the data has come from China. The clinical trials mostly have come from China, but given that the safety of the device has not been comprehensively tested and assessed, and here we are not only looking for short-term safety, and there's a couple of case reports that spoke about edema and that there might be issues with the photoreceptors as well. There's a more recent publication. But even before the more recent publication, the Chinese FDA classified the device. It was originally available in China. Now it's become a class 3 medical device. And unless they demonstrate safety, it's not allowed. So in a way, it's not used in China anymore, but it is available in some other countries. For example, in Australia and Malaysia, they're still using the device. So we know that it is efficacious. The data seems quite clear. There have been a number of clinical trials, and you can see that it is quite effective. But the rebound is also there. So it's not just one side of the story. So there's quite significant rebound with low-level red light therapy that needs to be understood. So there's the issue of rebound and the issue of safety with low-level red light therapy, plus the fact that you want a child to look into the device each day, 5 minutes, twice a day, then compliance becomes a factor as well. So if you start a child on this treatment and if they're not compliant, then your myopia is going to rebound. So that's another thing to consider as well.
Great. Thank you. Thank you so much for the wonderful discussion. I've tried the red light therapy and it's not easy. I'm pretty much everybody would find it difficult, especially the kids. So thank you. And thank you so much, Dr. Padmaja, for your time and a beautiful presentation. So can we have the slide for our next speaker? And it's our privilege to have with us Dr. Burton Kushner. Yes, and he's a professor emeritus in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin in Madison. So yeah, there is really no need for any introduction. He's like one of the biggest, most influential strabismologists and pediatric ophthalmologists. He has been the program secretary of APOS and the editor-in-chief of Journal of Pediatric Ophthalmology. And he was also the founding editor of the Journal of APOS and the co-editor-in-chief of Binocular Vision and Ocular Motility. And these are all journals that we follow regularly. He has over 225 peer-reviewed publications with 41 book chapters and 3 textbooks, and also the sole author of 2 textbooks. He has under his name 13 named lectures and received many awards, including the Heed Award, the Bressler Prize, and the Senior Honor Award from both the AAO and the APOS. And he's also been awarded the Best Physician in America for many years and is listed in the 20 most innovative pediatric surgeons by the top masters in healthcare administration. So his passion for strabismology is something that goes beyond, and he's someone who's so eloquent and he makes things sound so simple. So thank you, Dr. Burton Kushner, for being here today with us. And we welcome you, and we look forward to your talk on intermittent exotropia.
Well, thank you for that lovely introduction. I'm going to share my slides. If I can do this, it takes a second. And we're ready to go. So I was asked to speak about pearls in the management of intermittent exotropia. So this won't be one kind of continuous narrative, but a lot of, if you will, one-liners. And it is a pleasure to be speaking at this, I like the title, Eye-Conic Evenings with Pediatric Masters. I am on the advisory board of Novasight. That relationship has really no bearing on this talk. So exotropia, it's interesting how I'm very fascinated with how science works its way into art and vice versa. It's been represented in art for many centuries to depict the idea of a wide panoramic view. On your left is a Byzantine mosaic from the 5th century, and it depicts Christ with an exotropia. It's a common depiction of Christ in Renaissance art. The middle picture is from the Hagia Sophia Mosque in Istanbul from the 13th century. And even in modern times, the movie Jesus Christ Superstar had an actor playing the lead role, as you can see on the right, with a very obvious exotropia. So what is the metaphoric representation of that? Well, exotropes are thought to have or do have what's called panoramic viewing. It's almost as though they can see around corners. Gunnar von Norden had an anecdote of a patient of his who was a postal carrier, a mailman, who would drive down the street using his right eye to see the traffic and see the street, and his left eye to read the addresses on the mailboxes on the side. And when he had surgery, which fixed his exotropia, he actually missed this panoramic viewing after his surgery. So when an intermittent exotrope presents, and I'm talking now about a child, but I guess the same is true in adults, young adults and adults, it's important to note that the patient's control tells you if you should treat it, and the angle tells you how much to do if you're going to do something. There are some patients that have a very large angle deviation, but they control it well, and you may not need to do anything. There are some patients that have a small angle with poor control, and these patients are obviously frequently losing binocular vision, and they should be treated almost regardless of how small the angle is. So with that in mind, it's important to develop a control score. Something where when you look at your notes and you say the control is fair today, and last time it was perhaps good, you know you're internally consistent. You know this represents a change. And I think, although I think it's very important to have some control score, it's not really that important which one you use. There are a number that have been published, and as long as you're internally consistent. I personally use a two-phase control score. I give one score for how easily the patient breaks fusion, and a second score for how quickly they recover fusion. Because there are some patients, as I said, that break easily, but recover also very quickly. Some patients may be very hard to break down, prolonged cover test perhaps, but once broken, they have poor recovery. So I like to quantify both with my control score. Now, if a patient with intermittent exotropia comes in and they're very young, and I'm arbitrarily saying about under 3 years of age, you should note that there's a high incidence of postoperative monofixation as opposed to bifoveal fusion if they have surgery at a very young age. And it's not clear why this is. It might be due to the fact that you operate, you get that initial overcorrection that is desired, the patient's esotropic, and maybe in a very, very young patient, even a couple of weeks of being esotropic will cause them to lose binocular vision. On the other hand, it may be a pre-existing selection bias. Perhaps the patients with very poor fusion capabilities are the ones that come in early. And it's hard to assess that because we can't really do accurate sensory testing in a 1-year-old or 1.5-year-old. So I take the approach that if they're very young, I'll temporize and not do surgery young if I can. I temporize perhaps with alternate patching, with prisms, with over minus. There are various ways to do it. But if temporizing I'm sorry, my slides are on their own. If temporizing isn't successful, you just have very poor control. When I operate on these patients at a young age, I avoid a long-standing esotropia postoperatively. They're initially overcorrected at about a week. If they're still esotropic, I'll either patch them, put them in prisms, perhaps use phospholine iodide if that's available. It is off and on. It's very important to correct anisometropia in patients with shaky fusion. I think one of the most interesting chapters that I've read in our field is Art Jampolsky chapter in the 1978 New Orleans Academy transactions called Unequal Vision Inputs in Strabismus. And he points out that unequal vision coming from each eye is very destabilizing for patients with shaky fusion. So if you're going to cut plus, do it symmetrically. If you're going to over minus, do it equally and correct any significant or even small amount of astigmatism. Now, if surgery is indicated, I think all patients, not just the so-called divergence excess, all patients should have a 1-hour patch test to determine the maximum angle at both distance and near. And they should also have a measurement taken on a far outdoor target. And these tests are, two measurements are not interchangeable. Different patients have different mechanisms for masking a larger deviation, and a patch will bring it out in some, and a far distant measurement will bring it out in others. And you want to operate for the maximum angle that you obtain. It's noteworthy that for the outdoor measurement, I mean, if you can actually take the patient outdoors, I know that disrupts clinic flow, but if you can take the patient outdoors, that have them look at a flagpole or something far in the distance, that's fine. But if you want to take them to a window and have them look out the window, as you can see from that drawing on your right, the distance they are from the window impacts how much of their retina is subtended by the outdoor illumination coming in from the window. So on your left, the patient is close to the window, X distance away. It subtends 70 degrees on the retina, the window illumination, and at just double that distance, seen on the right, the angle is subtended is only 30 degrees. So you want to get the patient as close to the window as you can, but far enough away that you can get in front of them and do your prism and cover test. So I want to move on to this phenomenon I have named the SCOBY phenomenon. I formerly called it tenacious proximal fusion. For reasons that are too complicated to go into in this brief lecture, I won't explain why I've changed. But this is a very typical intermittent exotrope, 30 distance ortho near. And Richard Scobie observed that many of these patients, if you patch them monocularly for an hour, that near deviation will increase, perhaps to equal the distance deviation. And in my mind, the presence of this phenomenon foretells a better prognosis. These patients have a stronger latent fusional mechanism, which can help them stay straight after surgery. So Burian, as everybody knows, categorized exos as divergence excess, basic convergence insufficiency. And then the pseudo or simulated divergence excess is the patient that has the Scobie phenomenon. You patch them, the deviation in near increases. And many people use +3 lenses to bring this out. And what's interesting and not widely accepted or recognized is that +3 lenses at near and a patch test are not the same, although both of them may diagnose the pseudodivergence excess. And it's not explicitly graspable why these two tests can both bring out the same diagnosis. As I said, they're not the same. One test, the patch, the +3 lenses suspends accommodative convergence, and the patch suspends fusional convergence, which are very different. Yet, many, but not all patients will have the same response with each test. So it's important to really do both. Now, a very common question I get from a novice resident, I have a patient who's 30 distance ortho near, and they say, well, if I correct them for distance surgically, are they going to be esotropic at near? It's a very logical question. And the answer is in the vast, vast majority of patients, that doesn't happen, except in what's really a rare patient, in my experience, is the one that has a truly high ACA ratio. Let's talk about the characteristics of that. They present with an exo bigger at distance than near. It will not increase with a patch test because it's accommodative convergence that's keeping them smaller at near. It will increase with +3 lenses at near, but that should be done after you've done a patch test and before they're allowed to fuse. If you do a gradient ACA, which is not part of our routine, but minus lens at distance, measure them, -2, measure them, a gradient ACA will be high. And if you test them very near, like at 3 inches, again, closer than we typically do, they will typically have an esophoria at near, where most patients, and particularly exos, when you get in very close, you're cutting in closer than their near point of convergence, they break and go exo. And in my experience, patients that meet these criteria for a high ACA have 100% specificity and 100% sensitivity for having an esotropia near after surgery if you correct them to ortho in the distance. So once I learned that, I like to temporize in these patients. I'll temporize with minus lenses. High ACA means a small amount of minus will give you a lot of, as they say, bang for your buck. You'll get a lot of correction with a very small amount. But they will need a bifocal at near for the esotropia. But the important thing, in my experience, every one of these patients normalize their ACA by the end of the teenage years. And then they can be treated in the usual manner without fear of overcorrection. Now, what I'll call the newer, although I've been talking about this since the early 1980s, underlying principle for exotropia is that a divergence excess is probably not really an excess of divergence. It's probably an exotropia that has an excess of near convergence. And that could be fusional, it could be accommodative, it could be awareness of near or something else. And the other thing in the new concept is that there are myths regarding selective surgery. It's a myth that lateral rectus recessions affects the distance more than near. It's a myth that medial rectus resections affects near more than distance, and that R&Rs give you the same at distance and near. In most cases, you get what you need. And I'll refer you to this very interesting article by Steve Archer on this concept. I want to close briefly by talking about exotropia with lateral concomitants. So here's a patient, 30 distance, and in both right and left gaze, they decreased to 15. And the great orthoptist Sally Moore described that there's a very high incidence of overcorrection in primary position if you do standard surgery on these patients. Now, I've thought about this. What physiologically can cause this mechanism? 30 and decreasing in right and left gaze. Well, one way is if they're weak laterals, you're exo, and when you look to the side, the abducting eye doesn't move as far because of a weak lateral, and the exo decreases. Same in the other field of gaze. But it's hard for me to fathom that an exotrope has weak laterals. The other is if they have overacting medials. They're exo, when they look to the side, the medial pulls this eye in more and the deviation decreases. That must be what's going on in these patients, and that explains why they're prone to overcorrection. They have overly strong medials, and you weaken the antagonist, you'll get a bigger effect with respect to decreasing the exo. But this is recognized, but what's not widely recognized is if you have this pattern after prior lateral recessions, again, same thing, 30 distance, 15 right and left gaze, now the laterals are iatrogenically weakened. So it's a different mechanism than the de novo patient. And these patients are not prone to overcorrection in the primary position. They may, however, be overcorrected in side gaze, and you may need to modify your surgery or take that into account. With that, I want to thank you, and it was a pleasure to speak before this wonderful group. And as I say, may all the roads you travel lead to orthophoria. Thank you.
Thank you. Thank you. Wonderful talk.
Yeah, wonderful, concise, and very succinct talk. Thank you so much, Dr. Kushner. And I think we all face intermittent exotropias every day, but these are the little things that we'll need to kind of fine tune our surgery on. So with this, I mean, there's a lot of clarity that we got, but I'm sure there's still a lot of questions. So I invite Dr. Sandra and Dr. Manjula to lead the discussion. So maybe we'll take the first question from Dr. Sandra.
Yes, it's a pleasure listening to you, Dr. Kushner, and thank you for your talk. So my question is again on the patients with high AC or A ratio. I have a couple of patients waiting for surgery and at different ages. So as you said, you give them over minus glasses and wait till teenage. In your experience, does it disappear? The AC or A, does it reduce completely on the usage of over minus glasses? And if you decide to do surgery once they are older, what is the procedure that of your choice and what angle would you target?
So in my experience, I think when I wrote the article, I think I had seen about 18 patients in my whole career. It's really not common. If you just call it a high ACA because they increase with +3 lenses, that's going to be overdiagnosing them. But if you follow the criteria that I described, in my experience, every single one of them, and there aren't that many, they're rare patients, outgrew the high ACA by the end of teenage years. So they no longer needed to be over minus. They manifested their deviation, and you can treat them like any other intermittent exotrope with those findings. My personal bias is for symmetric surgery. I like lateral recessions in most patients. If you prefer R&Rs, I think that's perfectly acceptable.
Would you be targeting the distance angle or somewhat less than that?
I target, so if they're high ACA or were high ACA, the distance angle is always going to be bigger than the near angle. It wouldn't be a high ACA if the near angle was bigger. I will target the distance angle after a patch or after looking at an outdoor target, whichever is larger.
Okay, thank you, sir.
Dr. Manjula, please join in.
You completely floored us by your mesmerizing talk. I would like to ask you a lot of questions, but then I will start with some basic questions. What is the role of prism adaptation test to get the largest angle of deviation for exotropia?
It's a good question, and I don't have a specific answer. I actually, after I did I had several hundred patients that I did all these, I'll say, rigorous measurements on and wrote them up in several papers. I lamented the fact that I didn't do prism adaptation. I think that's a study waiting to be done. It hasn't been done to compare how prism adaptation compares to measurement after a patch test or looking out a window or outdoors. My instinct is it might be as useful, but I haven't studied it. The one thing I have done, and this, I don't always do this, but if I have a patient that looks like a divergence excess and I want to do a patch or whatever, I've found that what I call a very rapid prism adaptation. They're in the office, trial frame, I'll put in base in prism equal to their distance deviation in the frame, have them just read a paragraph or, for a minute or two, do a cover test, and almost always bring out the bigger deviation at near. Now, that's different than what you're asking. You're asking about building up the biggest deviation, the distance. I think that hasn't been studied. I think it's a study waiting for a younger person to do.
One more
I'm
question.
retired now. I'm not
Can I
seeing
ask
patients
one more
now, so I
question
can't
to
do
sir?
it.
Can
Yes,
I ask
ma'am,
one more question?
Just one more and yeah.
Yeah, one more question. Lots more to ask, but then for the shortage of time, I would restrict myself. What about the convergence insufficiency types, where you have a near deviation more than distance? Would you still go and do the R&R? I remember you talking about the Buckley's surgery, where you would upshift you induce a V pattern by shifting the MR up and the LR down. What is your preference of choice?
Yeah, so I have not found a surgical procedure in my hands that really equalizes the distance near difference in those patients. If you test most of the convergence insufficiency exos rigorously for ACA and so on, you'll find that they, for the most part, have very, very low ACA ratios. They have almost no accommodative convergence. And once you recognize that, to me, it makes sense that no surgical procedure is really going to equalize the distance in near. So what I used to do initially was operate for the distance deviation and then manage the near however I can with separate reading glasses, with prism, or if it's smaller, they're often able to control it. But then the procedure that you just alluded to that Ed Buckley described, to induce a V pattern by transposing the medials or laterals either up or down respectively. If you induce a V pattern, you will decrease the exo in down gaze, and we use down gaze mainly for near reading. And I think that's very effective, but nothing that I found is really perfect.
Have you done any study on that method, sir?
No, I haven't. I actually talked to Ed, who I know well, about maybe collaborating and pooling our patients together. But in my practice, just because I did a lot of tertiary care complicated strabismus, I didn't have that many of those patients after I had learned about it. So I could have pooled my patients with his, and we might have had a meaningful paper, but like many things, we just never got around to doing it.
Thank you, sir.
So,
Thank you so
Wonderful,
much.
wonderful. Thank you.
also a study waiting to be done by
Yeah.
one of you.
I think all of
Thank
us
you
are
so
leaving with a
much.
lot of ideas for new studies. That's
Can we
Thank you.
go to Dr. Edward Wilson since
yes.
Dr. Jane is not joined?
Yeah, so Dr. Saurabh Jain is traveling currently, so we'll wait for him for the last and keep him to the last. So we'll now move on to Dr. Edward Wilson, another stalwart. And could we have a slide up, please? So
Manjula?
So Dr. Edward Wilson is again widely respected for his research into pediatric cataract and surgical education. He's currently the Distinguished University Professor of Ophthalmology and Pediatrics and the N. Edgar Miles Endowed Chair, the Department of Ophthalmology at the TNOA Institute in Medical University of South Carolina. He has served as the president of APOS and the council chair of the American Ophthalmological Society. And he's been at TNOA Institute for the last 15 years. And I think now it's probably more than 10 years again, so maybe 25 years. He has received the Lifetime Achievement Award from the APOS in 2010 and the American Academy of Ophthalmology in 2016. He was elected to the prestigious Quinn Club and awarded the Claude Worth Medal. And of course, he has presented in several forums and has 21 named lectures to his credit. And he's written about 27 books and 250 scientific publications. But more importantly, he's a great teacher. He's mentored several pediatric ophthalmologists across the globe. And that's something I'm extremely elated and I'm so happy to have you here today with us, Professor. So we are looking forward to hearing you talk about pediatric cataracts and how you manage them. Over to you, sir.
Thank you. Let me share my slides. Okay. Get to presentation mode here. Well, it's my privilege to be part of this exciting webinar. I was asked to talk about perfecting pediatric cataract surgery. So again, just like Dr. Kushner did, it's going to be some pearls of ways that you can make your surgery better and get it as close to possible to perfect surgery. These are my faculty disclosures. So I'm going to talk about four things. One, reduce inflammation. And what I mean by that is induce the least surgical trauma. Secondly, I'm going to talk about using the best operation possible, not always the best possible operation, and I'll explain that. Third, customize IOL choices for the individual. I think we can do better than treating all 3-year-olds alike, all 4-year-olds alike, all of those things, rules of 7 and all of that. And last, reduce dependence on parental compliance. I think as we get more options, we need to try and use physician-directed medicines and reduce some of our dependence on compliance of the parents. And they have a tough job with putting medications into children's eyes. So first, reduce inflammation. Now, in pediatrics, as you know, it's different than adults. The eyes are very soft. You have to reduce the amount of leak from the wounds. So I like to use tight fit incisions that are very close to the size of the instrument that you place through that incision. Adequate irrigation. I like a Venturi pump machine because I can pump as much fluid as I need to. It's not gravity fed. Both of those will reduce the chamber shallowing and deepening and shallowing. If you have a lot of that chamber bounce, that induces inflammation. I want a constant deep chamber. I'm very careful as if the chamber starts to shallow, I change my hand position, make sure I can reduce leak, and I come off of the aspiration a bit. So those things will minimize chamber bounce. And also minimize iris touch if you can. Good dilation is essential if it's possible. Iris touch, iris manipulation, iris coming out the wound, all of those add to inflammation. And intracameral steroids. I've gotten to the point where in every case, I'm using intracameral steroids at the end, and I'm also using other ways, other types of steroids, and I'll talk about this a little later. But you see in this patient, this is a 4-month-old infant who had an implant with bicapsular capture and intracameral dexamethasone and a dexamethasone insert. So I was able to send this 4-month-old home with no drops. Now, here is what I normally do. If you're in a setting where contact lenses are impossible and you've got a unilateral case, I understand that you might need to implant. That's why I showed that bicapsular capture initially. But the least surgical trauma in a baby less than 7 months of age is to only go in once, use the vitrector, cut the anterior capsule, aspirate the lens, cut the posterior capsule, sew up the wounds with I like TNOA Vicryl. You may not have access to Vicryl, but I like TNOA Vicryl. And then at the very end of the case, no patch, no shield, no subconjunctival medicines. And if you do this without iris manipulation, this is that same baby first day post-op. And then you have less inflammation and less need for inflammatory medicines after surgery. Now, the best operation possible versus the best possible operation. I think the pearl here is don't try to do the best possible operation if you're operating in a setting where you don't have a good red reflex view with your microscope, you don't have the machine that you normally use. You really have to do the best operation possible. This is part of the art of this type of surgery, is try and figure out what is the safest operation possible in the setting you're in with the equipment you have. And I think that's important. So what I do at home might be different than what I do in a developing world mission setting where we've pieced together equipment and we're trying to still get a good outcome. So choose a surgical technique that can be safely done with the equipment you have available. I think that's really an important point. And don't feel that a video you watched is something that you have to do. I like bimanual techniques. I think they're more forgiving. I like to work one hand against the other. And as you know, you can't really use a second instrument like an adult with a phaco tip and using a second instrument because there'll be too much leak around that second instrument. I don't use phacoemulsification power all the way up through about age 30. And in my pediatric operating room, I don't even open a phaco pack. So I'm using all irrigation aspiration and a high-speed vitrector cutter when needed. This case that I'm showing, one that's probably a popular method for you, is to I've done aspiration and now I'm doing a manual posterior capsulorhexis and push the vitreous face back, and you can do this without having to do a vitrectomy. And you might choose this technique if the equipment you have doesn't lend itself very well to a vitrectomy. Now at home, I have I share machines with the retina surgeons, so I like their machines, and I often will take the posterior capsule through the pars plana. But if you don't have that equipment, then it's probably safer for you to try to avoid the vitrectomy. And here I'm just pushing the vitreous face back, and then I'll put my lens in, and you can do this with or without optic capture. This is more my go-to technique, just the one I like best for a young child. I've done a manual capsulorhexis, and now I'm doing after the lens is in place. So I like to put the lens in the bag while the bag is intact. Then I remove all the OVD, all the viscoelastic is removed, and then I go pars plana. Now, this is a 25 gauge vitrector. It requires a high-speed cutter. It requires a good red reflex view. So you have to have a quality microscope, and you may have them in some of your operating rooms and not in some of the satellite locations. I like this because I can cut a larger posterior opening than I would dare do from the front. And I just find that it's efficient, and I don't take any chances of pulling vitreous forward. I like to teach the fellows that if you're going to cut vitreous, cut it where it lives, and that's in the back, and not pull it forward by going under the implant or doing it before the implant is in place. I also advocate not using a trocar. The retina surgeons use a trocar for tool transfer. And in this case, we're doing one time in and one time out. There is no tool transfer. And so the trocar would get in the way. Plus, it's a very soft eye, and you would have to put the trocar in at the beginning of the surgery, not at this stage. Whereas at this stage, an MVR blade, this is a 25 gauge MVR blade, goes in very easily. It's one time in, one time out. And just to be cautious, some of my patients come from far away. I always sew the pars plana wound. People have published that even in children, they can leave them unsutured if they're 25 gauge size. I sew them all. I want to be careful, and I sew them all. Always remember that aphakic spectacles work great, and I use them. I think they're a placeholder. I know that you do see adults with aphakic glasses, but I at least prepare the parents for ultimately they're going to get the permanent implant. We're just choosing when to do the permanent implant rather than if we're going to do a permanent implant, because I think that parents want to know that eventually they're going to get modern technology and a better image. Now, this is just a word about optic capture. Posterior optic capture was popularized by Howard Gimbel. People did studies after that showed that in the very young children, perhaps under age 3 or 4, that you really needed to do a vitrectomy, that this probably was not going to be sufficient. I've heard, we were just in a meeting in Denmark, and I've heard surgeons say that with optic capture, that you should never have to do a vitrectomy, and I don't think that's true. Now, here's a case, and I make sure my fellows know how to do these. So we did this case where we did posterior optic capture and no vitrectomy, and I think the child was 4 or 5. We maybe could have done a YAG, but so we didn't. We did a posterior optic capture after a manual posterior capsulorhexis. This looks pretty good, but this child's complaining and the vision's dropped. And here's another angle of the same patient. That is a opacified vitreous face. And that's very difficult to YAG. I had to go in pars plana. It cleaned up very rapidly. So this is evidence that you may still have to do a vitrectomy despite posterior optic capture. Not saying that posterior optic capture is not a good technique. It locks in the implant, you get good centration, and at least in some cases, it reduces visual axis opacification. Now, if you leave the posterior capsule intact, and I know I advocated least surgical trauma. So case is going well, child is older, you're going to take your chances. You leave the posterior capsule intact. If you do that, follow your patients carefully. PCO, significant PCO, usually occurs between 12 and 18 months after surgery, regardless of age. But if you wait too long, if they get lost to follow-up, then it will fairly rapidly get thick. You'll get these puddles of cortex, as you can see in the upper left photo, and that makes it very difficult to YAG. Some of these patients come to me just to have the pars plana cleanup. I think it's very easy for people to do, but you have to YAG early. As soon as it's evident that you're going to have to do the YAG laser, do it early. Here's a successful, this one was done by one of my fellows. This is a successful YAG, and yet look at all that material just suspended in the formed vitreous. So of course this patient complained of floaters. So if you wait too late, even a successful YAG laser, because there's formed vitreous behind the posterior capsule, that it may just suspend there and unlike adults, stay in the visual axis. And then again, we have to clean it up. So all of these things mean that for me, I do more vitrectomy and more posterior capsulectomy, especially in kids I'm not sure how good the follow-up is going to be, because I with the least amount of surgical trauma. And if you have the good equipment, I'm doing more posterior capsules rather than less posterior capsules. Customize the IOL choice for the individual. We do this on every case. So we published in 2019 a regression formula that will predict, based on the biometry of the day of surgery, it will predict the future axial length. Then I take the future axial length that I've predicted for age 20 and put it back into my IOL formula. Then I can choose, if the child will be a good glasses wearer, I can choose to place an implant that is aimed for emmetropia at age 20. Then it will tell me how much hyperopia I'm leaving now. If I choose to aim for emmetropia because the child is not going to be a good glasses wearer, then it will tell me how much myopia I am predicted to have at age 20. And so I can work out, I can tell the parents what to expect. Maybe they'll need LASIK later, maybe they'll need an IOL exchange. So I advocate predicting globe axial length. We have validated this formula with a database from Brazil. One of my former fellows who came back for a sabbatical year, he had a huge database, so we were able to validate our formula on a different data set than the one that was used to create the formula, and it worked very, very, very well. This link below, if you screenshot this link below, my Antonio, our Brazilian fellow, has a spreadsheet. He's made it into a calculator So it's based on our formula, and you can plug in biometry and it'll do everything for you. So you can download that through this. It's on a website with the Brazilian Society of Ophthalmology. The second bullet here is toric IOLs work well after age 5. We also have a regression formula that predicts the future keratometry readings. But they don't change very much after age 5. And I don't do as many toric IOLs as I'd like because of cost. We have to charge the families. I don't like to do that. And especially since I can't promise spectacle independence, because they're still going to get a myopic shift with eye growth. Now, full range of vision IOLs, which are multifocals, extended depth of focus, trifocal. The full range of vision IOLs I don't recommend unless I have 2 IOL master axial lengths 1 year apart that show no growth. If the eye's full grown, you can have that conversation. Kids are very adaptable. They don't complain very much about dysphotopsias. But this technology is one of simultaneous images. And if you get a myopic shift after you've carefully predicted with biometry, if you get a myopic shift, which you're always going to get, if you get it, the technology works really terribly. You have multiple images, none of which are on the retina. And ironically, with the myopic shift, the child is miserable without glasses and is more spectacle dependent. If I have a monofocal IOL and a child's -1 or -150 or even -2, they're really happy. I mean, they could do just about everything. But if you have that same -1 or -2 in a multifocal, they don't like it at all. And they will be more dependent on their spectacles. So caution there. Here is the original article on the top. This is the validation study, which was published in the AJO 2024. And then another article that is now in press that shows the different ways you can create these formulas. And again, the calculator is at the link at the bottom of the screen. And here again, when the child becomes cooperative enough that you can do all the measurements and markings and things that you want to do, they work pretty well. And we've shown that you get less than a diopter of keratometry change from age 5 to age 20. We have that fiction was published in March of 2025 in the Journal of Refractive Surgery, and that reference is below. This is what I'm using though now for children where I can measure biometry awake. Is I like these monofocal plus lenses. They're an enhanced monofocal. They do not have rings. They don't have any dysphotopsias, but they're better than the old monofocals. They have an improved defocus curve. What that means is the amount of degradation in visual acuity that you get with every diopter of uncorrected refractive error is less. So if I leave +3 on purpose so the eye can grow into the implant, I want a lens that when the child happens to not be wearing their +3, I want the least amount of degradation in visual acuity. So that's why I pay attention to the defocus curve. And they also have been shown to have better intermediate vision when that's been measured as well. And at least for us in the US, I can use these lenses without an upcharge for the family. This is an Eye-Enhanced lens, but several of the companies have these enhanced monofocal plus lenses. Lastly, do everything you can to reduce dependence on parental compliance. Now, I'm a big fan. I don't think you have this in India. Rupal Trivedi in one of the recent meetings in India presented some of our data on how well it works in kids. This is FDA approved for children as well as adults. It's a dexamethasone insert that goes into the punctal, into the lacrimal punctum. If you don't have that, that's fine. Use intracameral antibiotics. I would not do a case without intracameral antibiotics. Use intracameral steroids. Dexamethasone is, you can easily find non-preserved dexamethasone. It will jumpstart your anti-inflammatory regimen. I don't hesitate to use triamcinolone. You can wash the triamcinolone so that it doesn't have preservative, or use Triessence, which is back on the market. But you can put it through a filter, even standard triamcinolone, and putting in some triamcinolone in the anterior chamber and leaving it there will give you about a week of coverage. This is a sustained release steroid. There's also one that goes into the anterior chamber. This one is easier to insert for me. So these are just some pearls. Try to get your surgery to reduce, if you can reduce inflammation by the least surgical trauma, do the best operation possible with your equipment, and don't get fancier if you don't have the proper equipment. You can't see what you're doing. Customize the IOL choice for the individual. Don't treat all 4-year-olds alike, and try the best you can as we get newer ways of doing this to reduce dependence on parental compliance. I don't use postoperative antibiotic drops. That may be controversial, but intracameral antibiotics really are very effective. And when you sew your wounds, I can't justify the post-op antibiotics in a child where it's very difficult to get them in. So I thank you for your attention and look forward to some questions.
Wonderful. Thank you so much, Dr. Wilson. I think I'm still not over your perfect rhexis, that perfect round. It's just simply beautiful, and a lot of learning points, a lot of different things that you do compared to what we do. So I would like to have our regional authority from Tamil Nadu on pediatric cataracts, Dr. Sumita Agarkar, with us. She's here, and I would love for her to have some questions. I'm sure she has many.
Actually, I don't have any questions. Dr. Wilson has almost answered everything. I was going to ask about the newer enhanced monofocal lenses, but in his slide, he has already mentioned that he has had good experience with them in children. Do you have an age cutoff for putting an enhanced lens? Like, would you do it in a 3-year-old? Or do you?
Yes. I don't see any downside to doing that. In my situation, I have Alcon lenses. So if I have to do the biometry asleep because the child's too young to do it awake, then I just pull the lens off the shelf. So because they just won't give me a consignment of those lenses that are a little bit more expensive. So because some of them would expire before I use them. So if I can get the biometry awake, if they're cooperative enough to do usually an IOL master, then I'll order the lens. So that's been my cutoff, but that's just logistics. I don't see any downside to putting them in early.
The children.
Yeah.
I have another question about the myopic shift, which happens. What's your best, whether would you go the cornea way by doing a LASIK, or would you exchange the IOL? Because now with 20 years down the line, now several of my patients are having -7, -8. So,
right.
So what's the best?
Yeah, I think if it's beyond the easy capability with LASIK, then I do an IOL exchange. I'm very comfortable with IOL exchanges. So if you get up to -7, -8, because maybe the growth was not what you expected, I'll do an IOL exchange. But I do a fair number of them, and they're not easy. So if the lens is in the bag, the risk you take is tearing things up, getting it out, and then trying to get the new lens back in the bag. So I'm comfortable doing them, but I know a lot of people are not comfortable because they maybe had one case where they sort of destroyed things inadvertently. But if they're under about -6 or so, I would rather have the refractive surgeon try to do it with the cornea.
Then the exchange.
Can I
Thank
ask a
you so
question?
much.
Can I ask a question?
Yes, ma'am.
What do you think about piggyback lens? Because some of these patients, they may not be fit for LASIK, and when they have -8, can we insert, because they have become adults, can we put a piggyback lens on these patients?
Absolutely. I published early on piggyback lenses in small children to get them to emmetropia, and then have have the top lens removed. But later on, going for an ICL or going for a special order myopic implant and putting it in the sulcus, perfectly acceptable. And I think that's often a good option. So I would definitely put that on the table along with the possibility of an exchange.
One more question regarding the unilateral cataract at a very young age. You showed a patient who was only 5 months old. So how do you treat them? How do you prevent amblyopia in these patients?
Well, I just hope that we get them early. The unilaterals, I try to operate at around that 6-week point if I can. And then we start the patching right away. So I don't like a long wait to get the contact lens on. We developed a lens constant. It's 111.9, if I'm remembering correctly. We developed a lens constant for our SilSoft contact lens. So I put it into biometry just as though it were another IOL. So I know what lens to put on the eye at the end of the surgery. So I like to start with a good image. If you wait 1, 2, 3, 4 weeks to get them to contact lens clinic, you've lost a lot. So I've got a good image right then. And because I only have 2 small incisions, I didn't induce a lot of cylinder. So I start patching right away. And I patch 1 hour per day per month of life until I get to half the waking hours. And then I do half the waking hours, and we see them frequently. We call the family, we coach them. It's if they sense that you think it's important, they'll go out of their way. If you treat it casually, so I think it's just compliance. It's tough. I mean, I know, and some of these microphthalmic guys, if you do OCT when they get older, they've got abnormal retina, so they may not developmentally have been ever going to get good vision. So then you don't blame the parents. But if they have good vision potential, it's all about engaged parents.
Dr. Wilson, I think, yeah, we just lost you there for a minute.
Oh,
could we have,
okay. All right.
Could we have Dr. Murli to ask his question? And Dr. Murli is also a very competent surgeon. He's a wonderful strabismologist as well. So, Murli, sir.
Thank you, Dr. Ed. It's always a pleasure to listen to you. We often are faced with a dilemma when the corneal diameter is borderline, let us say it is 10 millimeter, the white to white is 10 millimeter or less. So what would you do if you were to put an intraocular lens in a child with a corneal diameter less than 10? Would you do a ultrasound biomicroscopy to measure the bag dimensions? Or would you just base your decision on whether to implant a lens or not based on the horizontal white to white corneal diameter?
That's a good question. And we've studied in pediatric autopsy eyes, we've studied bag size. And so I've got a pretty good idea of the bag size, but anything above about 9 millimeter cornea, if I have to put a lens in, I will. I won't do it below 9. A 10 millimeter cornea, at least in our wet lab, the lenses like the Alcon lenses, those single piece lenses will conform to a small bag better than some of the other companies' lenses. If I don't think it can go in the bag, then I use the technique I showed at the beginning of the talk. So if you have a very small bag and a small corneal diameter, take a 3-piece lens, put it in the sulcus, and do bicapsular capture, because then all you need is a 6 mm optic to go through your rhexis. If you try to get that lens in a small bag, you might tear up the bag. You'll get so much ovaling that you might tear up the bag. So that's another, the sulcus, remember the sulcus is bigger than the bag. So if you can put the lens in the sulcus, but anchor it and center it with the bag, that's another way of doing it. It makes all of us nervous when the corneal diameter is that small, but sometimes you have no choice and you have to try.
That's wonderful, actually. Thank you so much. Just one quick question from the audience and from a friend. How do we confirm the completeness of vitrectomy when we are doing it through the planar route? Is there something how you like find out an endpoint?
You know, when you don't need to remove a lot of vitreous. I think you need to make sure there's not an intact vitreous face that lens cells could use as a scaffold. I tell my fellows that when they're learning pars plana, use some dilute triamcinolone. So dilute the triamcinolone, put it through your pars plana wound, and because it helps you to visualize the vitreous. Once you learn that, then yeah, it's pretty invisible, but I sort of move the vitrector around. Remember that a high speed vitrector, and I'm using 7,500 cuts a minute. High speed vitrector will not pull the vitreous into the port. That's what makes it so safe. There's no traction. So you have to move the vitrector in a circular manner, thinking about where you're removing vitreous so that you have vitreous removed the entire diameter of your posterior capsule opening. But it is invisible, and I wouldn't worry about doing too little. You don't really need to remove a large volume of vitreous.
Wonderful. Wonderful, sir. Thank you so much, Professor Wilson, for your really lucid talk and excellent points. I think a lot of us are going to take home today. So we move on to Dr. Arif Khan, who's going to be our next eminent speaker. And we'll have Dr. Saurabh Jain probably after that talk. Can we have the slide up for Dr. Arif Khan, please? So I had the pleasure of listening to him at the recent POSN, and that's when I was completely bowled over by the kind of insights he had on genetics. And I think that's the reason we wanted to have him here. I wasted no time in inviting him as quickly as I could. So could we have the slide for Dr. Arif Khan, please, Manjula?
Yes, doctor, once again.
Yes. Yeah, so I could share it from here as well, if there's a difficulty.
No, doctor, no, doctor.
Okay. So Dr. Arif Khan is the Department Chair of Pediatric and Neuro-Ophthalmology from the Cleveland Clinic in Abu Dhabi. And he's again someone who's been in pediatric ophthalmology, and he's a stalwart in the field. And now he's like doing a lot of work in genetics. Yeah, great. We have a slide up. So he serves as the chair of the editorial committee for the American Academy of Ophthalmology for the book. And he's also an executive board member of the International Society of Genetic Eye Disease and Retinoblastoma. He also serves as an editorial board member for the Journal of Ophthalmic Genetics. He's also served as an editorial board member and later as an associate editor for the Journal of for JAPOS. So again, an excellent lecture that I listened to, and I'm really excited to hear his talk going further. So his topic will be on how genetics helped him in his practice. So over to you, Dr. Arif Khan. We look forward.
Thank you so much, Sharita, for that kind introduction. Let me share my screen. Yeah, can you see it?
Yes.
Yeah.
And it's in slideshow, yeah? Okay.
It's not in slideshow. Yeah, it's okay.
Okay, so Congratulations to the Tamil Nadu Ophthalmology Association for having this webinar, and thanks so much for including me in it. I was asked to speak about how genetics has helped me, how genetic testing has helped me, but actually, I think it's more important to talk about how genetics can help, because knowledge of genetics is actually more important than genetic testing itself, and I hope you'll see why in this presentation. So let's see. I want to share with you a few things that I hear people say that sometimes bother me a bit. One is that nystagmus in an infant means poor visual acuity. I hear that quite frequently. Another is that since most retinal dystrophy is not treatable, which is true, there is no point to genetic testing. And the third thing I hear people say that bothers me a little bit is that genetic testing results can rule out certain diseases. I see people get relaxed if they do genetic testing for a certain condition, it comes back negative. They feel that they've ruled out those conditions. So these three things I want you to keep in mind as I go through some case examples. And I always feel very strongly that case examples are really a good way to learn when they're illustrative cases. And let's start with the first case. This case actually is a patient from India, a 3-year-old male who's referred for the evaluation of cone rod dystrophy. Nystagmus was noted at 1 month of age, and the child was diagnosed as poor vision based on that. There were also some retinal abnormalities noted, and an ERG was done at a few months of age. Based on the ERG, the child was diagnosed as cone rod dystrophy. A genetic panel was done, which was negative, but the diagnosis remained cone rod dystrophy, and the family was told that the child would progressively lose vision and would eventually be blind. The mother then became pregnant again and was told that very likely the unborn baby has a 25% chance of having the same blinding condition as the proband. And based on this information, the mother decided to proceed with abortion for the unborn baby because of that potential risk. This is all before I ever came to see the patient. Fast forward a few years later, the child is now 3 years old, and the child's vision seems good despite nystagmus. And that's where I see the patient. They come to me for another opinion. Now, what are the issues with this case? There are several issues with this case. One is the patient was diagnosed as having poor vision based on nystagmus. The second is that an ERG was done at a few months of age. It's very difficult to interpret ERG in a child so young, and that's something I would avoid because it's difficult to interpret unless you have very, very good controlled data. And the third issue is that the patient was diagnosed with a recessive disease without any genetic confirmation. It was just assumed that the child had a recessive disease. Anyway, let's see how this child is when he comes to us. His vision is subnormal. It's not horrible, but it's definitely subnormal. And clinical exam does show that there's some retinal abnormality. The patient also has myopia and astigmatism. Now, when we look at this child now at 3 years old, the retina is abnormal. There's a normal optos down on the lower, just for comparison. But to me, and for reasons I won't go into because of time, this looks more like a lack of pigment rather than a dystrophy. It seems to me to be a form of albinism. And sure enough, when we do an OCT, the patient has foveal hypoplasia. So it seems to me that this boy, 3 months old with nystagmus, actually has albinism. He doesn't have light skin pigmentation, so it seems to be ocular albinism. Ocular albinism can be a relatively static disease. It is relatively static, and it can have pretty good functional vision. So how can we confirm this suspicion of the diagnosis of ocular albinism, which is a much better prognosis than recessive cone rod dystrophy? Well, there is the gene for ocular albinism is known, and we can certainly do genetic testing. But there's something much more powerful that we can do, something that we can do with the help of somebody who's in the room, usually, and that's the mother. And when we take a look at the mother who's asymptomatic, you can see that she has these streaks of hypopigmentation, mud-splattered appearance. It shows up more clearly on the autofluorescence. This is the carrier sign for X-linked albinism. So we just made a genetic diagnosis without doing any genetic testing. This genetic diagnosis could have been made from the very beginning for this baby, had the people who were examining the child thought of it. The biggest problem is people don't think of X-linked albinism. It's a very underdiagnosed cause of nystagmus in children. We did genetic testing and sure enough confirmed the relative gene mutation. X-linked disease is fascinating in ophthalmology. I could spend the whole time just talking about it. In classic X-linked disease in ophthalmology, the males are affected and the females classically are asymptomatic and carriers with carrier signs. So anytime we have a boy who has an ophthalmic disease that could be X-linked, it's always important to examine the mother for potential carrier signs. I would say X-linked ocular albinism is the biggest culprit for being underdiagnosed because there's a very wide spectrum of presentation. There's another point I want to make about ocular albinism and albinism in general. These patients have nystagmus, and sure, they can have foveal hypoplasia and reduced vision and nystagmus related to that. But very often, the nystagmus is not from reduced vision, but it's actually from a miswiring, and it has nothing to do with reduced visual acuity. In ocular albinism and in oculocutaneous albinism as well, there's a misrouting at the chiasm, and there's too much crossing of optic nerve fibers at the chiasm. It disrupts binocular vision, and that is a major reason for the nystagmus. It's not reduced visual acuity. Just to remind you that normally a little more than 50% of the fibers cross at the optic chiasm. In albinism, it's more like 80 or 90%. This abnormality of cortical representation for binocular vision, this is a cause for nystagmus. It's not reduced vision. So please keep that in mind when you see boys with nystagmus. Always think about ocular albinism and look at the mothers or sisters who are around. The next case I'd like to share with you is a patient with blurry vision awaiting a kidney transplant. It's an inpatient consult. These inpatient consults for blurry vision can be annoying sometimes. Very often it's just a patient needs glasses, but that's not what it was in this case. This is a male in his 20s awaiting a renal transplant from his mother, and ophthalmology is called because of blurry vision. And when we examine the patient, we do see the reason for blurry vision. The right eye is shown, the left eye is shown, the right eye is similar. Can you see that multifocality to the lens? There's basically an anterior protrusion of the lens capsule centrally. It's causing a multifocality. This is what's causing the blurred vision. The patient actually has anterior lenticonus. Now, what's going on here? We have a young male who's developed anterior lenticonus, and he's also a patient with quote-unquote idiopathic renal failure awaiting a renal transplant from his mother. Anterior lenticonus in an individual with renal failure is screaming at us Alport syndrome. Alport syndrome is typically X-linked. This patient is awaiting a renal transplant from the mother. This is probably the only time in the history of ophthalmology that an ophthalmologist canceled a renal transplantation, because had this gone through, it would have failed, because sure enough, this child has Alport syndrome, X-linked, and the mother is a carrier. And here's the anterior lenticonus. You can see it better with the slit lamp exam. They also get some retinal finding as well. X-linked Alport syndrome, again, this is showing you, even without doing any genetic testing, just having some genetic knowledge is very helpful. There's no way this patient would have had very poor management had ophthalmology not been aware of this and put things together that anterior lenticonus in a patient with quote-unquote idiopathic renal failure is most likely X-linked Alport syndrome. The mother is most likely a carrier. This has all been confirmed with genetic testing. Case 3 Congenital maculopathy, nothing can be done. We see a lot of these patients. It's a 4-year-old with developmental delay and maculopathy diagnosed with congenital retinal problem at age 1.5 years old because of bumping into things. Patients also developmentally delayed. This was all assumed to be related to perinatal infection. It's an only child. The patient does have decreased vision, has some astigmatism, and you can see that maculopathy in the right eye. The left eye is also very similar. So what are the issues with this case? Well, certainly a presentation like this, when you have developmental delay maculopathy, it could be from infection, which was what was the case was assumed to be. But it also could be from genetic disease, particularly because it's so symmetric. You can see the symmetry here between the right and the left eye. Also, when we have patients who are developmentally delayed and have retinal issues, really we should have a lot of alarm bells ringing off, because sometimes this is the sign of an undiagnosed metabolic disease for which there could be treatment. So any child who comes in with retinopathy and any kind of neurological delay or neurological signs, I would consider this one of the indications for genetic testing. We did genetic testing for this patient, and we found a mutation in the gene that explains the retinal dysfunction. And unfortunately, there's no treatment for it. It's autosomal recessive, so that was not from infection. Interestingly, we found another separate mutation in a completely different gene that was responsible for the developmental delay. So these two things, developmental delay and retinal dystrophy, were not related at all. There's no way we could have known this without doing the genetic testing. Previously, everyone thought that it was just together. And as we're doing more and more broad genetic testing, we're finding more and more that patients can have more than one disease. They're not limited to having one disease. Unfortunately, we don't have any treatment for these two genetic diseases that the patient has other than supported care, but the parents wanted healthy children. And since now we know what we're dealing with, we can help them achieve that. It would have been impossible without genetic testing. The family underwent pre-implantation genetic diagnosis. The gene mutations were avoided, selected against, and the family now has healthy triplets. Not only that, they've eliminated this disease from their family. This would have kept recurring in future generations with nobody knowing what's going on had this not been done. Now this is successfully eliminated. So even if we don't have a treatment for a particular genetic disease, knowing what the condition is can allow genetic counseling, pre-implantation diagnosis, and can actually eliminate it from the family history. We don't have to go into the details of that gene. I'll share with you just two or three more cases. Another syndromic retinal dystrophy, nothing can be done. I already told you that if a patient comes in with a retinal dystrophy and they're developmental delayed or have any kind of neurological signs, alarm bells, I'm a big advocate for genetic testing, but I will agree that most patients don't need genetic testing. However, in a situation like this, I think it has to be done as soon as possible, because we have to make sure we're not dealing with an undiagnosed metabolic condition. This patient didn't come to me until he was 20 years old, but he had poor vision and generalized delay since early childhood. You can see the dystrophic retinas. Every patient with retinal dystrophy should have good phenotyping and molecular confirmation to rule out treatable conditions. And sure enough, this patient, he's intellectually delayed. He's not a good eater. He avoids meat because of unpleasant diarrhea. We did some workup. We did genetic testing just to get to the point. We found out this patient had A-beta-lipoproteinemia, or you might have heard of it, Basin-Korsweg syndrome. This is a defect in absorption of fat and fat-soluble vitamins. The reason that this patient had retinal dystrophy and neurological delay is because of this. This is really a tragic story, because had this patient been diagnosed as a child when he first presented, if he received vitamin therapy, the neurological and systemic complications and the retinal dystrophy could have been avoided. It could have been prevented by vitamin supplementation. So unfortunately, this is a sad case, but it's very instructive. any patient who comes in with retinal dystrophy and neurological findings needs genetic testing, particularly children. Here is, I think, the last case I'm going to share with you today because of time, a 6-year-old female with high myopia. Here you can see her coming in. We see a lot of myopia these days. But what's very important to do in these patients with myopia is to look at the slit lamp. And when we look at the slit lamp in this child, she actually had phacogenesis. She actually had myopia related to spherophakia. The lens, the anterior posterior diameter of the lens was larger than it should have been. This patient has a form of ectopia lentis. Now, the most common cause for ectopia lentis in a child is fibrillin mutation, and fibrillin mutation can also cause Marfan syndrome. So any child who comes in with ectopia lentis or phacogenesis or spherophakia, we have to make sure that they don't have fibrillin mutation because of the potential cardiovascular complications for this. So the family was informed of this, and they actually went out and had genetic testing, and it was negative for fibrillin mutation. However, this patient also had very flat corneas. Really, the ocular phenotype was pointing so strongly to fibrillin mutation, and that means a risk for Marfan syndrome. I insisted that they go for cardiac echocardiogram of the heart. And sure enough, echocardiography revealed dilation of the aortic root, which was progressive over time, and is now she's being treated with pediatric cardiology to maintain the aortic root diameter. This patient was negative for fibrillin mutation testing, but negative within the limitations of the method of testing that was done. Clinically, when we have a clinical suspicion for a diagnosis, particularly with particular diagnoses like fibrillin mutation, Marfan syndrome, our clinical impression is stronger than the results of genetic testing. And in patients like this, sure, you can have testing for fibrillin mutation, but regardless of the result, I would still refer these patients for cardiac workup because genetic testing is not perfect. It does miss things depending on the methodology used. And this is a perfect example of that. I don't think any of us would miss a patient with obvious Marfan syndrome. I think even lay people would recognize obvious Marfan syndrome. But when children present with fibrillin mutation, they don't always have these Marfanoid features. They come to us with ectopia lentis or phacogenesis. And it's important for us to recognize this and refer them for cardiac evaluation because this can be life-saving in these patients. And again, the earlier they're diagnosed, the better their prognosis from the cardiac standpoint. With this, I think I'd like to conclude. Things I hear people say, and I hope nobody will be saying this now after this talk. Nystagmus in an infant means poor visual acuity. Retinal dystrophy, that's untreatable. There's no point in genetic testing. Genetic testing results can rule out certain diseases. These things are not true. Genetic testing does have a role. Genetic knowledge does have a role for pediatric ophthalmologists. There are certain situations that we cannot manage optimally without some baseline knowledge of genetics. And thank you. With that, I will stop. And thank you again for including me in this wonderful webinar.
Thank you. Thank you so much, Dr. Arif Khan. I mean, there's a lot of new information from this talk, and in Tamil Nadu and in India now we do have genetic testing available, and it's not as expensive as it should be, and we do have whole exome sequencing, the ophthalmic panel, and all of this available. So I'm sure our practitioners would definitely benefit from this. So I would like to have Dr. Murali, who's on our panel, to ask a few questions.
Yeah. As always, Dr. Arif, it's a great pleasure to listen to you. I have a question. Sometimes, I mean, of course, most of us are not trained in ocular genetics. So we coordinate with pediatricians who are trained in phenotyping, and we try to arrive at a diagnosis. But sometimes on a whole exome sequencing, we get results like variants of uncertain significance. Whereas the clinical diagnosis may point to a particular disease, but what you get on genetic testing is a variant of uncertain significance. What should we be doing about this, and how are we sure that the lab is up to date about the mutation being referred to? Like at a particular point in time, it may be a variant of uncertain significance, which on a later publication may have been proven to be a causative mutation. So, what is your take on this?
Thank you. I would say that, it's so important for the clinicians to make as specific a clinical diagnosis as possible beforehand and have a strong hypothesis about what the diagnosis is before going to genetic testing. If you take anybody off of the street and you do whole exome sequencing, you're going to get all kinds of variants of uncertain significance. Sometimes you find variants that are predicted to be pathogenic, but they're not actually pathogenic in that patient. So it's misleading. So I would say that, the clinical impression and the clinical diagnosis really guides you to whether or not those VUSs you might find are significant or are potentially significant or just noise. If you have something that seems to be fitting the phenotype and it may or may not be and you don't have conclusive evidence, this is where you have to get other family members in. You test other members of the family to see if they have those variants or not. You look into literature, what's been proven before. But I would say the biggest mistake that I see is this over-reliance on what the testing says. And I tried to highlight that in the last case that I showed, which was a patient who presented with lens subluxation, really, really suspicious for fibrillin mutation. Genetic testing was negative. But clearly the patient has something that was not detectable by the methods of testing. And it was the clinical impression that determined that. So to answer your question, I would say what I would say to everyone is make a precise diagnosis as you can and don't depend on the genetic testing to give you the answer. The genetic testing is to help you confirm what your impression is. It's not a substitute and actually can be very misleading. So that's why really you have to have people who are experienced in making a precise diagnosis as possible and putting everything together like the pieces of a puzzle.
Great. Thank you so much for that question. Dr. Sandra, would you like to pitch in?
Yes. So, as in India, there is a lot of consanguinity in marriages, and we see a lot of patients with genetic diagnosis visiting our hospitals. So, I would like to know which are the inherited pediatric conditions where therapy may be available in the near future with newer technologies.
Yeah, well, in terms of if you're talking about gene therapy, I mean, that's quite limited and it's quite expensive. But I would say what's important not to miss is particularly the children who come in with early onset retinal degeneration. Sometimes that's the first sign of something broader, like, ciliopathies like Bardet-Biedl syndrome, or undiagnosed metabolic disorders like disorders of vitamin A metabolism. So what I would say is the most important thing to do is if a child comes in with pediatric retinal dystrophy or pediatric cataract. I mean, personally, I'm not comfortable if I have a child who comes in, an infant who comes in with pediatric cataract or pediatric retinal dystrophy without a molecular diagnosis, so I can be more comfortable whether or not it's the first sign of a systemic issue. But if that child's coming in with any kind of other neurological issue or delay, I would say it's an emergency to get genetic testing because it's far more cost effective than the old method. For example, a pediatric cataract where you're looking for, looking at the urine for, reducing substance and things like that. Now, having said that, you have to be aware of your practice situation. It may be that where you're practicing, infection may be a more prevalent cause for, patients coming in with retinal dystrophy, cataract, and developmental delay. So it's not always genetic, but at least in my practice, I'm always concerned about missing a treatable metabolic disorder when I see these children come in with pediatric cataract of glaucoma, retinal dystrophy, much more so with the retinal dystrophy than with the cataract.
Thank you, sir.
Yeah, thank you.
Can I
Dr.
ask
Smita,
one
one
more
last
question?
question.
Shruti, is it allowed?
Well,
We can ask it
yes,
in
we are running a little out of time. Maybe you could make it really quick, sir.
Okay. So, Dr. Arif, I had a 10-year-old child who had presented with bilateral optic atrophy and extensive workup for the child returned negative. We had got an MRI, done an anti-MOG, NMO, and a toxic screen, vitamin B12, RBC folate, everything came negative. So the child was otherwise fine. And so finally, we got a whole exome sequencing done and a mitochondrial sequencing done as well. So the child turned positive for a SPG7 mutation, which is essentially for spastic paraplegia mutation. So, but the child was evaluated by a neurologist and as of now doesn't have anything. So, is it? I learned by literature search that this is a very, very rare mutation. Occasionally can present with optic atrophy with only 7 or 10 cases reported in literature thus far. So is it possible for spastic paraplegia mutation to present with optic atrophy as the presenting diagnosis? And
Yeah, thank you for the question. You know, as we're doing more and more genetic testing, we're finding mutations in genes that are responsible for syndromes. Sometimes milder variants in those genes cause more isolated phenotypes. But I would be very, very careful before calling that patient isolated, because I have had patients who come in with retinal dystrophy and the genetic test, and they're otherwise fine. And then the genetic testing shows, you know, mutation in one of the genes for Batten disease or neuronal choroidal lipofuscinosis, which is a neurodegenerative disorder. And then we go back to those patients and they have very subtle findings. They have a mild tremor that wasn't noted before, or they have MRI and they have some leukodystrophy that is, you know, considered pathologic, although they were labeled normal. So to answer your question, yes, we are finding now milder mutations in the syndromic genes can cause quote unquote ocular only phenotypes, but I would be very cautious because the harder you look for the syndromic findings, the more likely you're to find mild manifestations.
Okay. Dr. Sumita, one last thing that she would like to add before we move on. You're on mute, ma'am.
Ma'am, you're muted.
No, I'm not asking any questions because these two other stalwarts have done it. I'm just going to say that Dr. Arif is going to deliver the Nagmani Dharmapuri oration on 15 December, and I'll take this opportunity to invite all of you to come and hear him in person and ask all the questions personally. So December 15th, 5 p.m.
Wonderful. Thank you, ma'am.
At Shankar Netralaya, V.D. Swami Auditorium.
Yes. So wonderful, sir. We are looking forward to meeting you in person.
Thank you so
To
much.
ask many more questions, I think unlimited, if you would permit. Okay, thank you so much, Dr. Arif Khan, for this wonderful lecture. And now I think Dr. Saurabh would not be able to join us because of his travel plans. So we're going to have a recorded version of his presentation, and we'll just have it up. And I would just like to quickly introduce Dr. Saurabh Jain. Can we have the slide up, please? This is for the benefit of our audience. Dr. Saurabh Jain is a professor of ophthalmology and the Year 2 academic lead at the UCL Medical School. And he's also a consultant ophthalmic surgeon at the Royal Free Hospital in London. He's basically trained as a fellow in adult strabismus surgery at the, I hope I'm saying it right, Leicester Royal Infirmary. And also he practices at the Manchester Royal Hospital. He's an active member of the Royal College of Ophthalmologists and the APOS. So he will now talk to us about infantile esotropia, another common situation that we all are faced with, and how he his nuances of handling it. Can we have the presentation, please? The audio is not there. Could you play it with the audio?
Manjula?
1 second, doctor.
It was available, audio was available. I saw it.
UK and the Professor of Ophthalmology. Afternoon, and thank you so much for inviting me to speak at the TNOA Pediatric webinar. My name is Saurabh Jain. I'm a consultant ophthalmologist in London, UK, and the Professor of Ophthalmology at UCL, which you can see from this picture. So it's been a real honor to be invited, but I have a small confession to make. I'm currently in a small boat that's going along the coast of Norway, and we just crossed the Arctic Circle, which does mean that although I have beautiful scenery, as you can see here, I also have very little Wi-Fi, so I may or may not be able to join in the discussion. If you did have any questions for me, though, please feel free to email them through at the end. So we're going to talk about infantile esotropia, and I want to start with a case of an 8-month-old boy whose eyes were seen to be deviating about 2 months after birth by his parents. Now, at the age of 8 months, this settled to a persistent convergent squint. There's no visual concern otherwise, and no family history of refractive error, strabismus, or amblyopia. On examination, effects follows well, but he does have a large angle alternating esotropia measuring about 50 diopters. He also has bilateral infraoblique overaction and cross-fixation. Now, cross-fixation for the younger members of the audience is a phenomena in which when the child looks to the side, the abducting eye does not move out completely and can give the appearance of a pseudo six-nerve palsy, but it soon disappears if you were to patch the first eye. So what is this and how can we treat it? Well, infantile esotropia is something we've known about for a long time. There's an early acquired, not quite congenital, esotropia, and it develops between ages of 3 and 6 months routinely. This is a very typical kind of esotropia because it's a moderate to large angle deviation. We'll talk about cross-fixation, but there are also other stigmata of reduced binocular input. So, for example, they have manifested in nystagmus, associated with vertical deviation. Other associations include infraoblique overaction and nasotemporal optokinetic asymmetry. This essentially just means that when they look at something that rotates from temporal to nasal, the saccades are fine, but from temporal to nasal to temporal, they are reduced. Classically, there's no associated refractive error or amblyopia and no neurological abnormality of note. There are two theories of the development of binocularity. Clodworth postulated that in children with esotropia, the keystone that completes the arch is missing. So then it doesn't matter when you operate because they just do not have this facility to fuse. Chavez felt that this problem was because of the eyes not being in the correct place. And if they were realigned early, you could give them stereopsis. And those are the two main theories that have been around for the last century or so. And there's still this debate ranges about which theory to believe and whether it is worthwhile operating early or not. We know a little bit more now. We also know this is a multifactorial neurodevelopmental disorder in which there's a failure of synchronous binocular input due to various causes, and some of them might just mean that the child is more susceptible to developing this, which cause impaired fusion and esotropia. We know that both the sensory and motor components matter. By the work of Mike Brodsky from Mayo Clinic, it was also shown that this persistent subcortical nasal word drift can cause a tonic conversion in esotropia. We also know the genetics are more important than what we had thought, although we still don't have the specific causal genes for this condition. This is an excellent paper talking about the congenital esotropia as seen across Europe in about 175 infants. Of those, 43% were constant and 25% were variable, and then 20% were about intermittent. Interestingly, a lot of the deviations were more than 40 diopters. These are large angle deviation. But here's the interesting thing. If the deviation was first seen before 12 weeks of age, 60% of them were intermittent, so they came and went. Where if we first saw them after 12 weeks of age, 60% were constant. Okay, that means if you have a small angle esotropia, that's intermittent, there's a much higher chance of resolution, up to 80%. The corollary is if you have a larger angle esotropia, more than 40 diopters, more than 10 weeks, seen at more than 10 weeks of age, and no hypermetropia, it's a much poorer prognosis, and they will rarely resolve and will need some kind of treatment. So treatment options can be observation, can be glasses. If there's a refractive error, you can use toxin or you can perform surgery. When there are so many ways of treating a single condition, that's usually bad news because no one treatment is the best. Okay, let's speak specifically about surgery for infantile esotropia. When should it be performed? Should we wait for amblyopia to be treated first if there is any? Should we wait for the angle to stabilize? How much surgery should we carry out? Should we do a bimedial recession or recess resect? Should we aim for over or under correction? I hope to answer some of these questions in this talk today. Talking first about surgical methods to use, you can either use a bimedial recession or a recess resect. I much prefer a bimedial recession because it's symmetrical surgery. So because of that, you reduce any induced incompetence. You're just sliding the muscles back, so they're very easy to revise if you need to. There's no tissue loss, and you can hide the scars much more nicely. If it's more than 50 diopters, some people have postulated adding in a third muscle. Personally, I prefer not to do that. I'd rather just keep the outer muscles as spare. I tend to use toxin to augment results of my surgery. Also, you know that hang-back techniques are the same as conventional techniques. This is a little illustration from Eugene Helveston's book, and it's so interesting to see how little we have moved in this debate about when to operate. So the timing of surgery depends on the surgeon's preference. So early surgery, most people will say is before 12 months of age, but there's been a vogue recently of earlier, up to 4 to 6 months. And then, especially in Europe, there are places where we leave the surgery until 18 months, up to 24 months. So there is still a lot of debate. Okay, so what can we do to resolve this? Let's look at the literature. Now, there's been a lot of papers recently that have shown that early surgery, which in most of the papers was before 2 years of age, improves stereo acuity outcomes, improves the visual and motor development, as well as better fusion and stereopsis. Okay. We also have been shown that you don't need to wait for the angle to stabilize before carrying out surgery. So that seems fairly cut and dried, right? That just means if you see a child with infantile esotropia, you should just operate. Or should you? Well, we know that ocular alignment instability is common in this group. We know that if you operate early, a quarter will require another operation for sure, up to 50% if you include the surgery on the obliques. The rate of requiring the second surgery can be up to 66% at 20 years and 50% at 10 years. And Herb Simmons showed very elegantly that children operated early had better growth stereopsis at 6 years of age, but had been operated upon more frequently. So it's all about a trade-off. And this is what we worry about if you operate too early. You have adults presenting to your clinic, if you do see adults with consecutive exotropia. And if you're not seeing any, it just means you just haven't been in practice long enough. So you can see here, this gentleman has limited adduction in both eyes. And if you look carefully, you can even see the scar here of the medial rectus recession. So this is the problem of early surgery, this consecutive exotropia, or it can be. And this is something that we all dread. Having said that, the bimedial recession, I think, is quite easy to revise. So here then is a slide comparing all the evidence we have of early versus later surgery. So what you're doing in early surgery maximizes your sensory potential, but compromises motor stability. But later alignment yields a much steadier result. However, it limits stereopsis recovery. So we just have to balance the trade-offs, and each family, each child may need a separate discussion based on these parameters. Here's another way though, toxin. So toxin has been used for a while in strabismus, but particularly in infantile esotropia, there have been some excellent studies looking at its use. Here's a study by Alejandra Campomanes, one of the largest in the world, looking at about 442 patients with infantile esotropia, less than 36 months of age. Of course, a large proportion received toxin. The surgical group was a bit smaller. Okay. And here's where you can see the comparison of the two groups. Interestingly, the toxin group was younger, both at the age of diagnosis as well as the age of treatment. And that was the primary difference between the two. The amount of deviation was almost the same between the two groups. And what this study found essentially was if your initial deviation was less than 30 diopters, then you did just as well out of surgery as you did from toxin. However, if your deviation was more than 30 diopter, you were better off having surgery other than toxin. It's almost double the success rate in the surgical group. So this is quite important. This is how I do the toxin. I use the same needle that I use for my adults for surgical proprioception. You go in medially, and then you move the eye, and then you go straight down with the medial orbital wall. Then you inject. Now, I think it's really important to do two things once you've injected. Keep the needle in the track for at least 60 seconds, and then sit the child up as soon as you can, because this will help you limit the most dreaded complication, which is ptosis, which can cause amblyopia in these children. So what you want to see 2 weeks later, want to see a bit of a consecutive exotropia as the whole motor system resets. Okay, this is another case. So you can see pre-op, this is just after the toxin, you can see the ptosis and the exotropia, and this is him a year later. Here's another case, this is what you want to see pre-op and 2 weeks post-op. Ptosis, but not obscuring the pupil, and exotropia. Here's another case, Matthew. You can see he develops ptosis and he actually lifts his chin up, but he also had a very good outcome. This excellent paper from IOVS did a meta-analysis on all the studies that have been published about using botulinum toxin and infantile esotropia, and is well worth a read. Some of the headline figures from this was the group success rate was 76%, although there was a large amount of heterogeneity. About 40 diopters pre-op, about 6 diopters post-op. Interestingly, the higher the dose injected, the lower the success rate. Now that might seem paradoxical, but I think it just reflects that the children who had higher dose were children who had a larger angle of esotropia. This study also found that EMG-guided injections, just as the one I showed you, were as effective as open sky, but both of these were much more effective than using transconjunctival techniques without EMG. Now, in my hands, if I'm going to open the conjunctiva, I'd rather just do an operation. So I prefer an EMG-guided injection rather than an open sky technique. What you want to do is to try and reduce the amount of complications like ptosis, conjunctive XT, and a subconjunctival hemorrhage. These studies showed that the rate of consecutive exotropia, so that's exotropia that never came back to normal, was 1%. There was a 27% rate of ptosis, but most of them resolved. There was some vertical deviation of 12%, subconjunctival hemorrhage, diplopia, but really the important thing we want to guard against is ptosis. So for that, as I said, two things: keep the needle in the track for at least 60 seconds, sit the child up as soon as you can. There's also one study that showed tonic pupil after toxin injection for esotropia in children. Stereopsis has been the holy grail. That's the reason we are doing what we're doing. That's why we're treating these children early. So did the children get stereopsis? Well, of all the studies, only 2 looked at this. Scott et al. Felt about a third had full stereopsis, but several had good motor fusion. And Gursoy showed that up to 86% in the toxin group and up to 80% strabismus surgery group did develop motor fusion. So this was interesting. It has long been felt that the incidence of infantile esotropia is slowly declining, at least in the West. This excellent study by Brian Money and colleagues from Minnesota looked exactly at that. And it was very interesting. They found the incidence had actually remained the same, but what had changed was the number of doctors. So there were more physicians providing care for these children. They were seeing half the number of people they would have been seeing previously. So they found a rate of 1 in 403 live births. Now, in the UK, that has not been our experience. We feel that the incidence is declining, not just of esotropia, but of all types of childhood strabismus. And we wonder whether because we have very good monitoring systems, children are screened early on and they get glasses or whatever treatment they need early on as well, through a nationalized health system, which is free at the point of delivery. So we planned a study looking at the to find the incidence of true cases, the clinical features, the clinical practice, and the outcome following treatment in the UK. So done by Patrick Watts and Damien Yeo through the British Ophthalmology Surveillance Unit. This is a unit run by the Royal College of Ophthalmologists, and it sends this yellow card to all consultant ophthalmologists in the country, asking them if they had seen any of the conditions on the card. And if you have, you tick it, and then you get a questionnaire to fill in. We carried out between 2017 and 2018 for 12 months, and we defined the kids we wanted in the study to have a non-accommodative esotropia, more than 20% diopters, diagnosed before 12 months of age, with a stable angle and no neurological disorder. Interestingly, all kids who were seen later than 12 months of age were excluded, even if the parents said they developed esotropia early on, because we wanted to remove parental recall as a confounding factor. We saw 57 cases over a 1-year period, and our rate was much lower. Instead of 1 in 403, we got 1 in 9,000 live births. The average age of diagnosis was 7 months. Of these 57 cases, 34 had surgery, 13 had toxin, and 10 were observed. Of the surgical techniques, 3/4 had bimedial recession and 1/4 had recess resect. These are the kind of deviations that we saw, and quite a large proportion had more than 40 diopter, and about 41% had a fixation preference, and some of them had infraoblique overaction, aberration restriction, all the other hallmarks of essential infantile esotropia. But here's the important thing. We also found that of the 3 groups, the observation group had a smaller preoperative angle compared to the intervention group, be it toxin or surgery, but also the age of intervention was earlier in the toxin group compared to surgery. And I suspect it's because people felt more comfortable offering toxin in the younger children where you couldn't accurately measure the angle, rather than offering more definitive surgery, which had its own issues of consecutive exotropia and further surgery. We also found that although the age of intervention varied from 6.5 to 28 months, it did not affect the successful motor outcome. We found slightly better motor outcome in the surgical group, although this was not statistically significant. All the corrections we saw were in the surgical group, though. And essentially, this paper showed us that early intervention, at least in our cohort under 12 months of age, did not really guarantee superior motor outcomes, regardless of the type of intervention. So this sort of mirrors really practice in the UK. So in summary, infantile esotropia is a condition that's usually apparent before 6 months of age, but not always at birth. We have multiple treatment options like glasses, patching, surgery, toxin, but timing of surgery remains controversial. A lot of the evidence seems to recall early being better, and I think that that's probably right. So in my hands, I'm operating usually before 1 year of age. I prefer a bimedial recession, although recess resect seems to be as effective, and do consider botulinum toxin as an alternative in your armamentarium. Thank you very much for your attention. I hope this was useful, and I'd welcome any questions.
That's great. Thank you so much. And now we have him live with us, so we are very happy to invite Dr. Saurabh Jain. I think he's just got enough Wi-Fi to join us now, so welcome.
So much, and thank you for putting up with my IT issues.
That's the reason why they put you last, so that we were hoping that you will join
somewhere, somehow you could join us. Right.
Thank you.
If we have Dr. Manjula with us, maybe she could start off with the questions.
She's not there.
Dr. Manjula? Okay. Could we have Dr. Murli? Murli, sir, do you have any?
Dr. Saurabh, thank you. It was a great learning experience. I have a question regarding the surgery. When you operate on these kids, you had mentioned bimedial recession. So do you measure from the limbus, or do you measure from the insertion? And does your dosage change? What is the max recession that you can do for these kids?
That's a very good question. I think, because of the disproportionate elongation of the posterior segment of the eye, a lot of people have said we should measure from the limbus. I have to say, I didn't measure from the insertion, because, this what works for me. So I know in my hands, if this is what I do, I'll get that result. I never do more than 6.5 millimeters, but I found if you do any more, with an adduction deficit, there increased risk of consecutive XT. So if it's a big angle, then I'll do maximal BMR and I'll put some toxin in at the same time.
Do you use adjustables in children? I mean, Dr. David Hunter's group describes a lot of adjustables in children.
Yeah, I think it's very challenging. To my mind, it's very difficult to get a meaningful deviation from a child that has just been woken up from anesthetic. Even in adults, we don't adjust for at least 2 or 3 hours after they've woken up because it's still, and plus if you're going to adjust, then you can't give them any, periocular Marcaine, so they wake up in pain. So for me, I don't think it adds a lot more, and the cons are quite a few, so I don't adjust postoperatively in children.
Dr. Sumita, do you have any questions?
I was just going to ask Saurabh if your strategy changes, if there is something like Ciantia syndrome or an nystagmus associated with esotropia, do you do more than 6 millimeter recessions? Because those are quite challenging cases and sometimes undercorrections are very common.
I agree, completely agree. Nystagmus blockage or any case where there's a null position and they hold their eyes in, then it's very difficult to. I have to say I haven't had to do more than 6.5. Maybe I've been lucky. And if that's the case, then I plan something for them later if I need to, once I've done the first surgery. But so far I haven't had to deal with it. Maybe luckily so. Because as you saw, we have quite a low incidence of infantile esotropia in the UK compared to
57 is a very low number.
So we think that is probably an underestimation, because what happens when you tick this box on the card, what will happen. You're going to get a big survey to fill in the next day. So a lot of people, some people don't always report because you're just creating work for yourself. But I like to think the pediatric ophthalmologists all did.
Another question, addition to that question, have you used Botox for augmentation for something like angle of 50? Would you just do, say, 5.5, a conservative recession, and just give a unit or two of Botox in each muscle? Does it work?
So I think, for me, the problem with Botox is it's a bit of a trial and error. You can never control exactly what. So whether I explain to my patients is surgery is like a screwdriver, Botox is like a hammer. You'll get the effect, but you can't precisely control the effect. So I use Botox really for children who have a bigger squint than 50 diopters. So that, I feel, okay, I'm doing my maximum surgery. I have nothing to lose by adding some toxin. I've not done like a 5.5 and some Botox, but then I just feel I can't titrate it very well. But I'll do 6.5 and Botox, absolutely. Like I did a 90 diopter ET, and they do quite well, actually.
Because sometimes the challenge is whether to add a third muscle or just do a little Botox augmentation. So
Exactly.
Yeah, well, I think Dr. Manjula is back. Just one question from her, and then we can wrap it up.
Sure.
Dr. Manjula?
So, hi, Saurabh. Glad to have.
Hello.
Like, I was just thinking whether you titrate the dose toxin according to the deviation. Does that happen? If you have a smaller deviation, lesser units, and a little larger deviation, more units, anything of that you do in your
This is a very good question. So if we
practice?
Yeah. So if you look at the Campomanes paper, they used 2.5, they used 5 units or 7.5 units. Okay, so they used 5 units for less than 50, 7.5 for more than 50 to each MR. I think that's a large dose. I only use 2.5 to each MR, no more. And I find if you do it properly, that's all you need, because the MR is a big, thick muscle. And if you get the toxin right, then it works really well. If you're doing it intraoperatively, I always recommend doing it before you detach the muscle, because otherwise the toxin goes everywhere. You don't even know, how much you got in the muscle. But for me, 2.5 works absolutely fine. So don't do more than that.
Okay. Thank you. Dr. Sandra, if you have any questions, you can ask. Otherwise, we can wrap it up.
Just one single question, Dr. Saurabh. I wanted to ask you, what is your window period in congenital esotropia? If you want to use Botox as a sole mode of treatment, would it depend upon when the esotropia has started in the first place?
It's hard, isn't it? I think if you're going to use Botox, I think you do it before 12, maybe 18 months at the latest. that, even if just doing an operation, to be absolutely honest. And that's what I've found.
Okay. Thank you. Thank you so much. I request now Dr. Sujata to take over Thank you so much, Dr. Saurabh.
I mean, at the outset, I'd like to thank Shruti for organizing such a wonderful webinar and the excellent faculty who gave such insightful talks. Though I have nothing to do with pediatric ophthalmology, except probably interested only in pediatric cataracts, it was an eye-opener for me as well. I'm sure all the general practitioners out there will benefit a lot. Particularly, at least you'll know where to refer these patients when you come across these patients in your general OPD. And thanks to the faculty from Tamil Nadu Ophthalmic Association with their wonderful questions and taking the whole thing forward. And last but not the least, we're waiting for Saurabh Jain to join, and he joined correctly at the right moment. So it was very useful. And all the talks were such wonderful things, and this was really an iconic pediatric ophthalmology webinar. Thank you, Dr. Wilson, for staying back and finishing this. So goodbye until we meet again.
Yeah, thank you so much and good night, everyone.
Thank you so
Goodbye.
much.
Thank you.
Thank you.